table because it's a rare disease. I make it try to make it simplify as hits of A to G of bleeding disorder. First, I will do some warm-up questions like eye opener and introduction. Then I will take A. A means assess the burden of the bleeding disorder. B, basic hemiastosis, which lead to the causes of the bleeding disorder. Then C is the challenges, what challenges we face in the diagnosis and treatment with the women and girls disorder. And then D, we will take some disease journeys of 3 prototype of the disease. We will go through it. And finally, I will hit means how I treat the patient in real world experience of the management. And if time allows us, there are some quiz questions of 15, I will take it. So, as I mentioned, first just warm up. As you know, audience will come. Question 1 is, what color is the ribbon for bleeding disorders awareness? Just keep in mind and check your answers. Red, maybe you're right. And question 2, when is the World Hemophilia Disorder observed? I made it March and April actually. Here is the evidence. March is actually bleeding disorder, which we are talking to today, rare bleeding disorder, and April is specifically for hemophilia. So this is how 2 warm-up question. And third warm-up question, which is very important. The question is why we are talking rare bleeding disorder. What is our objective of the talk today? Actually, we know the women and girls with bleeding disorder take an average much longer to receive proper treatments. This is because why? Because everybody know the women when they start menarche and it's later age as compared to circumcision the male. So this is the one thing. And second thing is polymenorrhagia and other symptoms which is really ignored and they don't reach the diagnosis for a long time. So it is the time to improve the quality of life for all women and girls for bleeding disorder. And we believe that raising this awareness and encouraging to the step forwards will help our life. So what are learning objects? There are 3 learning objects. I make it B, all B. First is the burden of the disease. We'll see what burden of the disease. Second is B is barrier. We wanted to check which barriers are there for making diagnosis and the treatment of the disease. And third is the diagnosis. Correctly diagnosis and correctly treatment is the object. So now, with this opening, now I will go A to B. What is the A? A is the assess of the burden of the bleeding encounter. So what do you think, what percentage of bleeding encounter in your practice in gynae ops? Here is the, this is the big data which indicates that trauma is the #1 cause of uncontrolled bleeding disorder. And very surprisingly, second cause is ops and gynae, which is from 4 to 6.4%. And if you go more in detail, and this is the publication which has seen in 113 national organizations, they have found about 25,000 rare bleeding disorder is reported. This is the common from hemophilia to vulnerable brain disease, and these are the uncommon disease which are actually heterogeneous. Source of data is differ because of socioeconomic influence, but I will go in detail now. Prevalence of the RBD is mostly they are autosomal recessive and they may affect symptoms like factor 7, Glanzmann disease, factor 13 deficiencies. We'll see in detail further. Now, assess the burden. You have seen there is burden, and number 2, assess the disease. So what common symptoms bleeding disorder in women include? You usually see long-lasting bleeds like after cut and surgery, long-lasting and heavy nosebleeds like more than 10 minutes, and the patient having history of gum or tooth extraction bleeding long-lasting, and family history of bleeding disorder, and heavy menses more than 7+ days, and frequent and large bruise, and postpartum bleed, and lack of iron and anemia and needs of blood transfusion. This is the common scenario we see. How I make it more, like most frequent symptom we see is mucocutaneous bleeding, mucosal tract bleeding, and excessive bleeding at the time of invasive procedure. And especially rarely we found also like bleeding at labor and delivery, even the patient is not known of the disease. And second thing is life-threatening symptoms. Sometimes they landed like CNS bleeding, umbilical cord bleeding, and some GI bleeding, and spontaneous abortion and the bleeding disorder we found. So we'll discuss all these things today. So in general, symptom women are high risk of bleeding and their complication during menstruation, pregnancy, and childbirth. So this is important we are talking about today. We know that pregnancy and delivery pose a special clinical challenge. Why special? I would say, think if everybody know during pregnancy, some factor which I mentioned here, fibrinogen factor 7, 8, 10, and 1 will brand actually increase normally during the pregnancy. And this is also make it difficult to make a diagnosis. Even the patient has a normal factor, it means they have deficit also. So this is how we discuss now. Now, after assess, then the B is the basic hemostasis. So it's very important to understand the cause of the disease. We should know that what is the basic mechanism of hemostasis. So there are actually 3 steps. Number 1 is vasculature. Number 2 is platelets. Number 3 is proteins, which is called coagulation cascade. Now, how it happened, just understand this one diagram is important for all of you. So here you can see if anything happened, injury to body, first step is what happened, primary hemostasis. And primary hemostasis, there are 2 steps, vasoconstriction. First, it causes constriction of the blood vessels, but that limits the blood flow, number 1. And number 2, in primary hemostasis, what happened, platelets, they recruit more platelets and they form plaques. So this is the first step we call it the primary hemostasis. And then only takes a few seconds, coagulation cascades activated, which we call as a secondary hemostasis, which we call as a coagulation path. You have read this in your student life residency, extrinsic and intrinsic path actually is there, which are clotting factor. Actually, these are the proteins, mostly they are formed in the liver, and there is cascade of the actions, and eventually they form fibrin that make as a heart clot. Now you are expert, primary hemostasis, constriction of the blood vessel, platelets, and coagulation cascades. So now you will see if any disturbance in there, you will find bleeding disorder, and you will find rare bleeding disorder. We will see. So number 1 is platelets. If anything in the platelets low, we call it the thrombocytopenia. There are 2 factors. Either they are destroyed or they are not produced. If increased destruction happens, usually immune phenomena. You have heard about ITP, Evans syndrome. These are the things, increased destruction. Other non-immune phenomena like TTP, DIC, this is the immune, here the platelets are destroyed. Impaired production, it can be acquired, it can be congenital. Acquired can be from malignancy to drug, or from nutritional deficiency to aplastic anemia. And congenital, there are so many things are there, but we will focus today one of the rare disease in the female we call it the Glanzmann thrombocythemia. So we'll talk about this. Now, second cause of coagulation cascade. You have heard about the extrinsic and intrinsic path. I will not go to in detail, just remind your basic of your residency and studentship, what you have learned, that it starts with the factor 8, and then factor 10 is the common factor, then factor 5. This is called extrinsic path. So if factor 8 is low, we call it the hemophilia A, and factor 9 is low, we call it the factor hemophilia B. And here is intrinsic other path, we call it activated by the tissue factor, which is actually cleaved by the 1 Willebrand factor. If this activate is common factor 10, this is how, these are the cascade. And finally, they form, as we discussed before, stable clot. So you notice if any factor deficiency is there, naturally, the patient will be bleeding disorder. So what we'll focus today, we'll focus number 2, factor 7 deficiency, one of the rare bleeding disorder in the female. And number 3, we will focus on acquired hemophilia, we call as a, when you find autoantibodies there, and those antibodies there, they form as acquired hemophilia. So this is how we'll focus on this. And third thing is, I will take you one challenge, one Willebrand disease factor, one of the example. Sorry, 1 second. Hello, can I speak with you half an hour? Yeah, can I speak with you half an hour in some urgency? Okay, thank you. So with this now, see, we'll go to the diagnostic challenges, women and bleeding disorders. So this is publication which actually highlights the importance of the rare bleeding disorder. Here you can imagine, this is from ASH, which is one of the, you can say, the one of the best conference, ASH, and the publication in the Blood. They have published that 1 in 1,000 individuals have bleeding disorder, but they don't know it. Could you one of them? This is one of the article which was published. I will go through this way. So what is the diagnostic? First is the diagnostic challenge. So how is diagnostic challenge and what we use for diagnosis? So I will go through one challenging case, like 18-year female who had history of heavy menstruation, and it lost 8 to 10 days. And she was taking and struggling with iron deficiency anemia since menarche, and she has also history of excessive bleeding during removal of the wisdom teeth at the age of 40, and she has no any family history. Now, just keep this in mind, how this patient's journey, you will find, how difficulty to go. So now, it is based on this article, what they found, 30% of women who have heavy menstrual bleeding in their life. And very interestingly, multiple studies, they have shown 15 to 30%, they have underlying rare bleeding disorder. So heavy bleeding disorder defined as more than 80 ml menstruation bleeding cycle per, but this is very difficult to find clinically, however. But this is the major cause of absence in the work and the school. And it leads to the 2/3 of the hysterectomy in the women in the reproductive age. And it has been shown to profoundly negative in the quality of life. The population prevalence of the bleeding disorder may happen in 1 in 1,000. So what is the problem with making the diagnosis? The problem is lack of the recognition between normal and abnormal bleeding. This is very important. And number 2, challenges in the terms of the lab testing. We'll see now. So there is one scoring system we call as a BAT. BAT stands for Bleeding Assessment Tool. So what they use it actually, this is how there are 14 factors. And factor is also from 0 to 4. You calculate from this is online. You can see if it is more than 6, we call as abnormal. There is something abnormality we call as a bleeding disorder. Now, when this BAT score published online, very interestingly, after 4 years after launch of this score, they found about 20,000 who completed self-BAT score. They found 44% abnormal bleeding score. This is very interesting. And this patient was referred to hematologist for further evaluation. And then this BAT score, they also expanded to the teacher and nurses for the awareness. Now, then other problem. So first is the assessment with the BAT score. Second is the bleeding testing. And the testing is again, there is challenge. Why challenge? Because there is less accurate of the testing. What happened, that when any patient bleeds, what we check? We check CBC and coagulation. Usually this is normal, we sit comfortable, but we should have to think beyond this if any patient has BAT score more than 6. So there are some special tests which should be done by the hematologist. So now, this is how we do it, coagulation. We do, suppose if PT is abnormal, we say is factor 7 deficiency. If APTT is abnormal, we say is factor 8 and 9 deficiency. If both is abnormal, there are some other factors. Similarly, if thrombin time and PT-APTT abnormal, we call as a fibrinogen deficiency. And if all is okay, we call as a factor 13 deficiency or von Willebrand disease. So there are these things, we focus on these things and how we label to the patient from grading from 0 to 3. What is the 0? 0 means asymptomatic, no documentation bleeding, but there is laboratory diagnostic. Grade 1 bleeding means bleeding is there at trauma or drug injection. And grade 2 bleeding is spontaneous minor bleeding happen with the minor wounds, and grade 3 bleeding is life-threatening bleeding. So this is how we testified. Now return back to our case, which I made a challenging case. Maybe you remember, 18-year girl, heavy menstruation, no family history. What happened? This girl went in school. In school, she was given a lecture. Let's talk about period website. So she used this website, self-BAT score, and she quantified her factor was 7. So she, and as I mentioned, more than 6 means abnormal. So she went to family physician, and family physician checked CBC, and CBC hemoglobin low, iron low, and coagulation was normal. So she was given initially, oral medication, but oral iron she cannot tolerate. So that's the reason she was referred for IV iron to give this patient. So when she came to hematologist, So as their BET score was high, so hematologist was smart enough, so he did some special test in her case, and she found he checked von Willebrand factor and platelet aggregation test. Platelet aggregation test was normal, but there were deficit in von Willebrand factor, so she was diagnosed as a type 1 von Willebrand disease, and she was given desmosine trial and other medications. So this is how, journey of the patient. Number one is von Willebrand disease is the rare, which is affected. Number two is the women and bleeding disorder. The problem is, we know hemophilia, we always think that hemophilia means men because of XY disorder, because of Y. So you can see, if level is less than 1, we call it a severe hemophilia. Level 1 to 5, we call it a moderate hemophilia. Usually it happens to male because of XY disorder, but don't forget there is hemophilia carrier as well. And there are asymptomatic hemophilia carrier, and there is also symptomatic hemophilia carrier. So what is this you can say here? This is the father who is XY, and this is mother who may be carrier. So, the disease is XY, like this is the son, this is affected is hemophilia, and this is the girl's not affected, and this boy is not affected, but this girl is again affected because of the carrier. So keep in mind that even sometimes carrier can have bleeding. So if there is family history there, so you have to think about this. So third thing after coagulation and von Willebrand is platelet. So as I mentioned, platelets numbering is actually may lead to misdiagnosis because there is platelets may be dysfunction that we call the platelet function assay. We'll talk a little bit later that lead to some disease like specifically Glanzmann thrombocytopenia. So this is how, warm up to you to understand why the disease is ignored, what is the problem, and what we do in, maybe seen in the gynae ops, they usually give adjunct therapy, and even some family physician, they do adjunct therapy like tranexamic acid, hormones to stop the bleeding without checking any rare disorder. And some, physician, they also replace FFP to replace some factor, and cryo some replace the factor, and some also give some heavy bleeding, they use PCC as well that replace some factor. But once you send to hematologists, they will replace accordingly specific replacement products that we will discuss in shortly, which factor is deficient, how to make a diagnosis, and then do it. So this warm-up, eye-opener, ABC, assess, basic, and challenge, I will go some prototype of the disease journey from D1 to D8. What is the D1 and D8? D1 means definition, D2 is demographic, and D3 is disease association, and then disease process and disease presentation, and the diagnosis and treatment dilemma. So this is how I will go. First disease is Glanzmann thrombocythemia. Now D1 means define. How is defined? It is a rare autosomal disorder. It is affected men and female equally. And demographic, how it is common? It is common in 1 in 1 million. So if UAE population is suppose 10 million, so you will find 10 patients per year. So epidemiology character, this is already mentioned. Now, they are classified depending on the number of the level of the platelet dysfunction. If it's less than 5, it is 75%. And if it's type 2, it's 15%. So this is classification. So how they present in your practice in gynae ops, what the goal, they usually from during the childhood, they have some history, gum bleeding, epistaxis, but maybe, as I mentioned, there may be some factors are there, it may be ignored, but when especially she start menarche, these things actually worse, they call menorrhagia. And even if the diagnosis is not met on this time, sometimes, later after 20 or 30, when they deliver the baby, then they find excessive bleeding also. This is how mentioned. So now, spectrum and classification of the disease is different from epistaxis to gingival bleeding to menorrhagia. It may require severe transfusion in some cases, first clinical manifestation of the Glanzmann thrombocythemia. Now, the thing is, severity depends. So in women, heavy bleeding is often observed at menarche, and the circumstances of the diagnosis, GD, in the adolescent female. So what we do, first thing is what we do coagulation path with the fibrinogen, it is normal, and CBC normal. So what is the next step? Next step is you do platelet function. What is the platelet function test? This is how platelet function test we do. Here you can see this is a normal person, normal control person. You can see epinephrine, ATP, collagen, their graph you can see. But what happened in Glanzmann, it is deficit. They will not work like this graph. So this is how we diagnose Glasman thrombocytopenia. And other way, Bernard-Henry syndrome, actually this is abnormal, only this one. So this is how physicians make a diagnosis. Now, furthermore, you see in Glasman, like coagulation normal, platelets normal, but what is the problem? Problem is platelet aggregation, which is you have seen absent or severely diminished. And next step is they will do flow cytometry to see the level of the Glasman. It can be type 1, type 2, depending on the severity of the disease. So once it made a diagnosis, so what is the next step? Next step is to treat the episode and treat the bleeding during surgery or invasive procedure. So there are 3 steps. One step is conservative. Second step, as platelets is not working, so platelets transfusion. Third step is you can use factor 7, recombinant factor 7. I go one by one. Local is what treatment, just pressure and local hematostasis. You can use it, you can stop the bleeding. And the second thing, as I mentioned, platelets. Now, the thing with the platelets is there is chances of alloimmunization because already patients have developed antibodies, GP2B and 3A and anti-HLA there. So this causes also refractiveness to platelets and also cause infection and immunological transfusion reaction. So the third thing, which is very safest in GT, which we use in our patients, like before surgery or sometimes during bleeding, we use like 90 mcg per kilo at the time of the bleeding, then every 2 hours, then we monitor accordingly, will show in small time now. So what we learned in GT, that current standard treatment is to platelets transfusion. And if you available, the factor 7 is effective in all age group. And they have shown that bleeding episode is stopped in 91% efficacy. In surgical bleeds is about 100% efficacy is shown. So after this one prototype, which is dysfunction of platelets, now we'll go to the coagulation. In coagulation, the rarest disease, other disease, which is found in congenital factor 7 deficiency. D1 means define. How you define factor 7 deficiency? It is again autosomal rare recessive disorder. Men and women are affected equally. Most common rare congenital coagulation disorder, and it is deficiency is factor 7 deficiency. Now, how it is common? It is common 1 in 500,000. It means in UAE population, suppose 10 million, so it will be 20 patient per year you find. So number of clinical, how it's present, again, bleeding pattern similar to platelet disorder, which we mentioned before in Glasman, same like, epistaxis, erythrosis, and menorrhagia, mucocutaneous bleeding, and peri and post-operative bleeding. So one person should have the familiar, if the patient has the history, family history, all this or anything, you have to find out this the call. Now, the UL symptoms, you can see 38 to 38% epistaxis and menorrhagia 10%, and sometimes they present the severe 11% CNS bleeding and GI. So it's very important to understand this. And how to make a laboratory diagnosis is very easy to make. Just PT will be prolonged, isolated PT, and factor 7 will be reduced. So this is how the patients, and you have to make differential diagnosis with the factor 7 deficiency with the liver disease, because liver is the main center which make a factor 7, and some other disease, lupus anticoagulants, and some patients who take oral anticoagulant like warfarin, they have also factor 7 deficiency, and plus DIC. So complication may sometimes, if you ignore the patient, they can present in some complication like CNS and GI bleeding. So it's very important to identify the patient and to treat accordingly. So how to treat? So there are again 2 things: to treat the bleeding episode and prevent perioperative bleeding. So how you stop the bleeding? You have to give therapeutic dose like this. You have option. What option you have? Number 1 option is recombinant factor 7. You can give this one. Number 2 is plasma-derived factor 7, which is prepared from the plasma donor, which may result in transmission of blood-borne infection. And third option is PCC, which is also pooled donor plasma, which also actually lead to the high thrombogenic risk. And other, you can use tranexamic acid sometimes, and if it's fibrin glue, and sometimes people use some hormones as well to stop the bleeding. But the important treatment is recombinant factor 7. Which is indication. What is the indication in the dosing? The dosing is very small. It's not a high dose like in other condition. We use 90 mcg per kilo. Here is only 15 mcg per kilo is enough, and you can give every 4 to 6 hours till bleeding is stopped. Now, factor 7 is optimal replacement therapy, and it can be used on the demand or before surgery. We use to patient admits surgery, before surgery, intra, peri, intra, and post-operative, like in this patient, and it is very safe. Now, I'm giving example, surgery in women with a rare bleeding disorder, like, you heard about Glanzmann thrombocythemia and factor 7 deficiency, like this. So what we do, to decision to undertake surgery in these rare bleeding disorders should be considered very carefully. Surgery should be performed in center where you have clear-cut hematology and gynecologists are available. They have clear-cut good cooperation, because this you can see one of the publication in which type of surgery in women which they found. Surprisingly, here you can say 53 women with the factor 7 was given. You can see the major surgery with the ops and gynae, and other is the ops and oral and like orthopedic. So major surgery was done. So which major surgery indication female specific was done for menorrhagia, ovarian cyst, prenatal diagnosis and labor. They use in these conditions actually factor 7 with the rare bleeding disorder. And you can say so what was the surgical management during pregnancy and delivery? Pregnancy may require factor replacement, and delivery should occur in conjugation with the factor 7 deficiency. So going back to that study, actually what they found, procedure and outcome, 3 major gynecological surgery, all were successful, no adverse effect. And similarly, the data which I present, STR and IF7, it also 6 major gynecological surgery, which was also found was quite successful. So similarly, we do in our hospital practice, we admit 1 day patient before, we check the level, whatever the factor are, and then, we start treatment, and next day surgery, then perioperative, and then post-operative we do accordingly. So this is how surgical we do it. So summary, rare bleeding disorder, we have seen the recessive affecting men and women equally, and surgery and invasive procedure may be needed to manage these things as well. So after these 2 disease, there is 3rd disease, which is really very important, which we call as a acquired hemophilia, or in other terms, we call as a peripartum acquired 8 inhibitor. Why peripartum inhibitor? I will go shortly. So D1, again, define. How you define acquired hemophilia? Again, this is a rare bleeding disorder. It's autoimmune disorder, actually. In these, what happened, the women, usually they are normal hematostasis. They have no problem. What happened? Something happened, they develop some antibodies against to the coagulation cascade, and the coagulation cascade not work, and then you find how common it is. 1.5 patient per 1 million population is there. And most important thing in graph, you can see this blue is actually for female and dark is for male. You can say the peripartum inhibitor, usually the median age is 34 years. You can find this is the age in which you find very high acquired hemophilia group, and similarly in a very elderly patient. So 2 populations are important, peripartum and elderly male and female, they are important. Now, pregnancy associated. Often they occur first pregnancy, surprise, 74% they happen in primary gravida, and usually occur 2 to 4 months after delivery, and it may occur up to 1 year postpartum. So these are the acquired hemophilia. They bleed, they happen something, bruises and all these things. I'm coming shortly what happened. So pregnancy associated acquired hemophilia usually occurs, though it's 1 in 350,000 births, but it happens rarely. So now, mortality rate is very bad disease. There is so much high mortality. Actually, the causes which are found mortality in idiopathic about 200, malignancy about 60, but peripartum is also not low. It is about 26. So how they present? So any lady who delivered the baby 1 week from 1 month, 2 months, 3 months, you notice if anything, mucocutaneous bleeding. Remember, mucocutaneous bleeding, which shown in the figure as well, is self-explanatory. You can see it, and plus epistaxis or anything, menorrhagia or anything, or sometimes life-threatening condition or surgical bleeding. So think about this. Now, how we make a diagnosis, as if any patient come with mucocutaneous bleeding, you do CBC and coagulation. And in coagulation, what you will find isolated APTT. So next step is really APTT you have to do mixing test. If mixing test is corrected, it means there is factor deficiency. If it is not corrected, you will go subsequent step and you will find this is acquired hemophilia. So now what is this concept of mixing test? Just bit I tell you. What happened if you see in this diagram, 100% patient plasma, and prolonged APTT. This is called acquired hemophilia. Now what we do 50% in patient plasma and 50% in normal control. So if despite of this prolonged APTT, it means there are inhibitors that are not correcting, we call it acquired inhibitor, acquired hemophilia. And if it is corrected, we call it a clotting factor deficiency. So this is how we do mixing test. Now, what is the clinical management of acquired hemophilia? First thing is stop bleeding. And second thing is to remove and clean, inhibitor which you have. So these are the two things are very important. So how you do stop bleeding? Again, the first line therapy are two recombinant factor 7 and APCC. You have two things are there available. So acute bleeding management. So what is the how you treat with a recombinant factor 7? It is again high dose. It's not like in factor 7 you use 20 mcg per kilo, but here you use 90 mcg per kilo every 2 to 3 hours till bleeding stops. And then you decrease the factor. How it acts, you can say this is the factor of coagulation. And what happened here, if there is inhibitor, they kill all the factor 10, 8, 2, not working. But when you give this one factor 7, you see it bypass the path and it activates the coagulation system. Now, benefits of using recombinant factor is number one, you can do flexible dosing. Safety profile is already very proven, and it is recombinant. It is not from the plasma, and there is no certain contraindication is there. And how you assess the hemostasis, again, there is difficult to assess. The only is the clinically you can assess the disease of the monitoring. Now, the consensus for clinical monitoring for bleeding episode. This is actually consensus by definition. If strong consensus, we call it 90%. If 75% agreement, then measure is like 50 to 75%. No consensus is less than 50%. So what happened? There is expert consensus on a statement of the evaluation of bleeding and hemostasis. You can see these are the things: GI, neuron, and kidney, from where this is female, dental expression, nasal. So these are the consensus. I will focus on postpartum hemorrhage, female genetical tract bleeding. You can see there is 100% consensus indicator of the treatment effectiveness, and 100% consensus that worsening of condition you have to give. Optimal assessment is there 91%. So they are consensus you should have to give factor 7. So first line treatment is the factor 7. You have to control the bleeding. And second line, we use sometimes rituximab also to irrigate the factor. So with this rare 3 prototype disease, as I mentioned, Glanzmann, factor 7 deficiency, and acquired hemophilia, what we are seeing, rare bleeding disorder, heterogeneous group of disease, there are technical limitation, as I mentioned, just CBC and coagulation is not answer. You have to go through. So accurate diagnosis is very critical to ensure the appropriate medical care. Accurate assessment of bleeding score is very important. As I mentioned, their BAT score you have to go through. Now, going to real world practice in our hospital, there was 31-year female a few years ago. She came again with bruises and with bruises. Actually, she went abroad for these bruises. This is surprisingly anyway, because CBC was normal, coagulation normal. So she was moving here and there GPs. So finally she went to abroad and they were sent back again. Nothing could work. So when it backs to Tamam Hospital again, when it comes to bruise, what is the rule number one? Rule number one is what? Nothing replacement, good history and physical. So what is this? What found in our patient, in this patient, we found the patient had delivered the baby 3 months ago. And she has heavy menses started and she was using oral contraceptives. So here is the key. And she had mucocutaneous bleeding. So here is the key. What happened? Hemoglobin dropped because of bleeding. Platelets, this is the reactive high than normal. WBC normal high. So first thing which we did, coagulation, isolated APTT high, and other factors were found negative. So what is the next step? As I mentioned, next step is mixing test actually. So mixing test was done, it was not corrected. So this is typical acquired hemophilia, which I mentioned here, which has happened especially in this age group. So, history, physical, make it our life easy. Listen to your patient. He's telling you the diagnosis himself or herself. So this is the step one. Now, associated condition, pregnancy often appear first pregnancy, which I mentioned, often happens 2 to 3 months. So this is typical, and this happens first. This patient also primary gravida, 2 to 3 months, and having bruise and bleeding, and CBC, and was checked, and she was moving here and there. Finally, anyway, we make a diagnosis, and what is started treatment? Started treatment to stop bleeding. Factor 7 was given, followed by steroid and cyclophosphamide. And you can see FPTT normalize. And this is the factor 8 increase after giving the treatment. So this is how case follow-up. So here you see FPTT normalize, and this is factor 8 increase. Now combination of cyclophosphamide given, and factor 8 inhibitor also decrease because of treatment. Now, what we learned in this case, remember, when you have any patient like this one, postpartum and mucocutaneous bleeding, do CBC and APTT. If the APTT is problem, do mixing test, and you will find if inhibitor level is there, mixing test will be not corrected. And rule number 3, what is rule number 3? Never forget rule number 1, which is nothing replacement, good history and physical. Each patient is telling you what is my diagnosis if you listen properly. And so this is how now I've gone through these things. I have gone through all the steps from A to G. I treated how I treat the patient. So this is a finish. If you have any question further, otherwise I will ask you some questions next 10 minutes, some board review discussion, or you can say the consultation, which we see especially from gynae people. So this is first question, first quiz, 39-year female, routine blood investigation. She had history of hypothyroidism. She has platelet count was good before 120,000, and later she found platelet count was low. So my question is, what should do first step? So first thing you will do, review the peripheral film. Why? Because platelets clumping, pseudo-thrombocytopenia can occur via EDTA. When platelets clump together, they are not counted by electronic particle counters. So you have to use citrate blue top bottle to avoid the artifact. So this is the step 1 to reveal real thrombocytopenia or not, number 1. Number 2, hematology was consulted from gynae. Again, what was the female? 24-year female and 36 weeks pregnancy. Why they called us? So they said the patient had developed thrombocytopenia. Her platelets count before was between 84 and 115, but now it's 32,000. Hemoglobin also dropped from 10 to 9, from 11 to 9, you can say. She has not any bleeding so far. And other things which was worrying, she has high LFT, you can say, about 10 times higher LFT, and blood pressure is higher side. Please keep in mind what you will do first thing, blood smear, what you will see in the blood smear, you will see schistocyte. Why? This is typical HELLP syndrome. So HELLP syndrome, what you do, it occurs especially in later stages of the pregnancy, especially in this, you see, 36 weeks. And MAHA means hemolytic anemia, microangiopathy. She is likely to have schistocyte and smear. And 30 weeks pregnancy, this is typical HELLP syndrome diagnosis. And if it is not corrected after deliver the baby, then it can be TTP later on. So now third, again, consultation, 32-year female with thrombocytopenia. Family physician from the gynae, they are saying is 45,000 platelets before, and now it is 42,000. Otherwise, patient is fine. And blood film, she has reviewed is large platelets, and they found there is no schistocyte and there is no platelets clumping. So please help us. So how do you help this patient? You will say, don't do anything. Normally, don't need treat. This is typical ITP, by the way. Because this is isolated, there is nothing in the phlegm, coagulation normal, everything is normal, and there is no history of bleeding, and 30,000 is cut off. Before 30,000, we don't treat the patient. Now, another female, another consultation from the gynae. Female undergoing surgery, she went very well. She used also heparin as well, and she was, because she was catheter, she was given vancomycin as well. And after 6 days, she later developed thrombocytopenia, very bad thrombocytopenia, only 9,000. All the things are normal, coagulation normal, blood film is normal, no problem. So what is the most etiology? Drug-induced thrombocytopenia. Please remember this also. Keep everything in mind. Be broad-minded. So number 5th, again, gynae consultation. 34-year female, 32 weeks of pregnancy, no complication, and she's fine. Platelets count is 85,000. Now think in mind, 85,000 platelets, 32 weeks pregnancy, there is nothing clinical problem, no bleeding, no bruise, film review, there is no clumping, no schistocytes, blood pressure normal, everything is normal. What do you think? What do you recommend at this point? Keep in mind, answer yourself, I would do observation. Why? This is typical gestational thrombocytopenia that occur in later stages of gestation and mothers. Normally, patients are asymptomatic, and study shows 50,000 platelets is enough even for epidural block. ITP occurs in early pregnancy, not later. So usually, this is typical scenario of the gestational thrombocytopenia. Now, another scenario, a lady, 26 weeks of pregnancy, gestation, and it is her first pregnancy, and blood pressure is 160/90 past 6 weeks. And 24-hour protein measuring is 1 gram protein 24. Thrombocytopenia is there, mild. And film shows also 1 schistocytes. LFT is normal, coagulation is normal. What do you think? It is HELP or what is this? This is preeclampsia. Yes, typical. How? Mild thrombocytopenia, mild MAHA, no coagulation, severe hypertension, and there is no evidence of liver disease. But there is proteinuria. This is typical preeclampsia, and you know the treatment, you are expert of these things. Now, going same, which I discussed, 25-year male, Glanzmann disease, how you treat the patient. As I mentioned, Glanzmann disease, treatment is factor 7. I will not go in detail this one. And now just little bit, hemophilia, there are 3 from mild, moderate, severe. How you define it? Suppose any patient who is less than 1, we define it as severe, and moderate 1 to 5%. Why I'm showing you this one? Because usually consultation come from gynae. Next question. 19-year female, mild hemophilia, factor is 15%, and she's undergoing for some surgical procedure. You wanted to help him. How you wanted to help him? We need 50%. So you have to give factor 8 and to replace the factor 8 to increase the patient's better. So now again, 26-year female, pregnant, 39 weeks of pregnancy, and she has von Willebrand type 1. And again, you have to give epidural block, gynae consultation. What you do? So you have to give von Willebrand factor 50 units per deciliter to make the consultation more than 50%. So similarly, one very common scenario, patient having heparin in the hospital, the platelets drop significantly, and you have seen the hit. It happens especially 5 to 10 days after heparin exposure, and how to score the hit analysis. There are T4, thrombocytopenia, timing, thrombus, and other factors. So this is how you do it. And now the few last is cholesterol, like any patient who is admitted, suppose a lady was admitted for a pancreatitis, hospitalization. What happened? Platelets dropped to 65,000. What happened? Your typical smear says is very large, several schistocytes, means very severe MAHA. So this is typical TTP. So how you make TTP diagnosis? Always remember ADAM 13. And how you treat the TTP? By plasma pheresis. Now, another gynae consultation, patient wants to, something having the brain mass and glioma, and it's actually under neurosurgery, sorry, and the platelets is 48,000. What you want? This is just, I wanted to show you how much platelets in certain condition, like uncomplicated patient, less than 10 is enough. If septic, more than 20. If undergoing any major surgery, 50 is fine. If neurosurgery and ophthalmology, 100,000, we need it. Now, this is how, how you make it the diagnosis of Glanzmann, like no aggregation, only one side is restaurant. And similarly, other way is the Bernard-Sandy syndrome. We make it like this way. So now, final, I think I have gone through so many things. And as somebody has said, in teaching, the greatest sin is to be boring. I think maybe I have not done sin to bore you. I have gone through the eye-opener, introductory question to warm up from the bleeding disorder, the causes, and what are the challenges. I have gone through some rare prototype of the disease from Glanzmann disease and factor 7 deficiency and acquired hemophilia. This was the goal, to tell you all these things. And please, I'm very happy. Put your questions in the chat, and let's see which questions you are coming from your side. Thank you very much for listening me. Thank you. Okay, thank you very much for asking me the questions. There are two important questions. One is regarding the Glanzmann thrombocythemia. So if the patient is admitted with a normal platelet count, but patient is bleeding, what do you think? You will do transfuse? As I mentioned, the problem is not platelet count. Its problem is platelet dysfunctional. So it means you have to treat it. Yes, definitely treat it. If you available platelets, yes, transfuse platelets. Otherwise, as I mentioned, there is chances of alloimmunization, and there is also Glanzmann, they also refractory to platelet transfusion. Even you give, it may not work. There is chances patient may continue bleed. So if you are available, you have to use, other factor, Ringerman factor 7 like this. So this is the treatment, a triplet treatment, which I mentioned before. Number one is local treatment. Number two is platelet transfusion. And number three is recombinant factor 7. So my answer of this question is yes, you have to treat it if the patient is bleeding. Don't count the platelets count. This is also mislead you. So it's very important. If patient is bleeding, you have to stop bleeding. You can say it's emergency. You have to treat it. Otherwise, patient will bleed and it will severely anemic, and this will be the problem. So I hope this is the answer of first question. Number two, is there any relation of endometriosis and late pregnancy? Endometriosis and late pregnancy, I think this is question from gynae-ops. I am not familiar with these things. Any bleeding disorder, I can say you, but there is chances. There are so many bleeding disorders. As I mentioned, most of the bleeding disorder they cause mucocutaneous bleeding. So naturally, there is a continuous cutaneous involvement, and there is healing environment is there. They may lead to some phenomena, and this can lead to some problem. This is the problem also. So you have to treat accordingly. But anyway, it's better to discuss with the gynae-ops. Third question is, can you please elaborate more on the self-bed slide? Yeah, self-bed is very nice. It's very nice question actually, and very important. This is actually, you can say, unfortunately, is very missed even in our practice, even GPs, family practitioner, even gynae-ops, even somewhere, even some specialist services. Bed score is not checked. It's very important, especially the patient. Even you don't have time, you can give them website. Just put in a website self-calculated bed score. It will come. And next visit, even patient come to you and they can find the bed score. Again, I mentioned in bed score, there are 14 factors. If you allow me, I can show you in my, yes, there is one slide actually from, you're right, this is very important bed score to understand. So this is the bed score. Here you can see there are 14 factors actually, and the number was given from 0 to 4. What are those factors? Like epistaxis, and you see none, very less, and only small consultation need. Number 3 is packing. So this is how, these can go. Even patient herself or himself, they are very smart. They can see how many type of epistaxis. They can give the number, and then cutaneous bleeding, and bleeding from minor wounds, and then oral cavity, GI bleeding, and then hematuria, tooth extraction, surgery, menorrhagia, postpartum hemorrhage, and hemarthrosis, CNS bleeding, and any other bleeding. So these are the 14 factors, and each factor is from 0 to 4. And you can ask the patient in next visit, they can bring to you. If less than 6, nothing to worry. If score is more than 6, it's better. And CBC, and you check CBC and coagulation. So first thing is BAT score. If BAT score is fine, and second thing, as I mentioned, CBC and coagulation, and that is fine, then it's very unlikely any disease. But if BAT score is disturbed, scoring is like 7, 8, 9, 10, even more score, this is very alarming. And even your CBC coagulation is normal, it means this is beyond the CBC and coagulation. In that case, patient need platelet function assay, patient need platelet aggregation test. And in coagulation, again, you have to check vulnerable brand factor, and sometimes, hidden factor like factor 13, when you APTTPT is normal, but you will find factor deficiency. And even sometimes, sometimes coagulation is like borderline, but you find some surprise, very, you can say moderate level of factor 7 deficiency, or factor 12 deficiency, factor 10 deficiency. So this is how. So answer to your question is, BAT score is very important, and self-BAT score is very important. And this is my slide. If you can take picture, or you can go in the Google, just put BAT score. It will come, automatically. You can calculate yourself. Your patient can calculate yourself. And next visit, you can discuss and elaborate properly whether this patient really need hematology service or not. This is very important. This is the step 1, actually. Assess the bleeding. BAT score will help you. Number 1, A, assess, and B for blood test, and C for consultation, and D for diagnosis. I would say ABCD. Assess the score with the BAT, number 1. B for blood test, CBC coagulation. If it is beyond this, C for consultation hematologist beyond the CBC and coagulation, and then D for make a diagnosis and make the life easier of the patient. So this is how BAT score we discussed very nicely. Now, what can you tell on case of pregnant lady had 14 miscarriages, 2 babies born with intracranial hemorrhages, all in investigation are normal? I think so this is the typical question. It's a good question. Very sorry to hear about this one. The thing is, I think maybe there is something missing. And missing again. Even some good hematology center, there is not so many tests are not available. What I'm talking, even beyond the CBC coagulation, there are some specific tests which do here in some centers. But even beyond this, there is some very rarest disease which I didn't mention here. This is, you can say, 1 in, you can say, 10 million people. So in those cases, I think they should be referred to some specialist coagulation center where they do it accordingly. Now, follow up on the question earlier, clotting was normal. Do you think any coagulation disorder in the mother could have contributed to the baby's intracranial hemorrhage? Yes, it can help. As I mentioned, there are some even the rarest disease, it can happen. This is typical, mother has the problem and the babies have, like, it means there is some congenital, which is carry on in the family, and it happens. And some rare disease, eventually we find out. We have these type of patient. We don't even have those tests here in UAE. We can say that one of the rarest disease, I will tell you. So these patients need really further investigation. Yes. So I think we are on time now. Time is finished. And thank you very much for listening me. And hopefully I didn't bore you, as I mentioned. Teaching may be the sin. So it should be properly, explained to you. I always remember, in short, in summary, BAT score is the number 1, blood test number 2, and then consultation to hematologist. Thank you very much. With this, I end my talk.